All right, we'll give everybody a few minutes to start coming into the room. Thank you all for being on time. I should have got some theme music. I messed up on that. I'll do that next time.
What would you choose?
Oh, that's a lot of pressure on the spot. And we're live? Oh my gosh. I don't know.
We've been rewatching MASH lately. I think the MASH song would be cool.
Yeah.
Without the words.
The Millionaire theme song stresses me out. I always like that one.
All right, well, we will get this going. So first and foremost, thank you all for being here today. And thank you panelists for bringing your talents and expertise to this virtual series in hopes of planting seeds conducive of a healthier and more equitable Louisville. So Grow 502 was created with one goal in mind, and that's to extinguish the detrimental health disparities so many of our community has faced for decades. These health disparities are not ones that have come one year just to wither into thin air. They are here, and these disparities are rooted within our neighborhoods, within our school systems, even in the food that we eat and the hospitals that we visit. So Grow 502 is merely a seed for advocacy, education, and innovative health promotion that will hopefully inspire and influence the Louisville community into being a part of precautionary measures needed to alter these harmful realities. So today marks the first day where our steps are to be taken in this direction. So through February and March, Grow 502 will be relentless in our goal and in our mission. So for those of you here, thank you again, and thank you for joining us in this fight. So today I have the pleasure of introducing our spectacular moderators, Cassidy and Liz. And I want to encourage our audience to be a part of this discussion. And when the time is allotted to you, please feel free to participate. So without further ado, let's uproot the weeds of maternal mortality. And you all can take it away.
Thanks, Sonu. We just want to start by introducing our wonderful panelists that are talking through this case today. So we have Dr. Miller. He is the Division Director of Maternal Fetal Medicine at University of Louisville Hospital and also serves as the Chief Diversity Officer for the Uofl Health System. Cheney Williams is a student midwife and a full spectrum doula, also working with the Louisville Doula Project.
Sorry about that, guys. Representative Attica Scott serves the Kentucky House District 41, and she currently serves on the Education, Elections, Constitutional Amendments, and Intergovernment Affairs and National Resources Committees. Dr. Ann Wallace is an associate professor in the Department of Epidemiology and Population Health, and she's the director of our MPH program in Global and Maternal and Child Health.
So we will begin the panel. So yes, this panel is called Uprooting the Weeds of Maternal Mortality. We've already introduced our panelists, and I will have Liz take it away.
Okay, so to begin, we kind of just wanted to give some brief definitions of maternal mortality and pregnancy-related death and just how the two kind of differ from each other. So maternal mortality is the death of a woman while pregnant or within 42 days of termination of pregnancy. So this is irrespective of the duration and the site of the pregnancy from any causes related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So pregnancy-related death, on the other hand, is the death of a woman while pregnant or within 1 year of pregnancy from a pregnancy-related complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiological effects of pregnancy. Next slide, please.
So to give you all an overview of what maternal mortality disparities look like in the US compared to other countries, this graph on the left shows the US's cases compared to other countries that are of similar economic status. So you can see that our score, we have 26.4 per 100,000 deaths, and that is remarkably higher than similar countries like Germany, France, Japan, England, Canada. This graph, this figure on the right is showing the distribution of pregnancy-related deaths by when they occur. So about 38% occur while women are pregnant, 45% within the first 42 days after delivery, and 18% within the first year after that 42-day mark. So that is the difference that Cassidy was talking about with maternal mortality versus pregnancy-related deaths. And Kentucky's mortality rate in comparison is 19.4 deaths. It is actually worse than the national average, and the US has a grade of a D- in overall maternal mortality, and Kentucky has received a grade of F- currently. So we are significantly doing worse than the state or the nation as a whole. Next.
So to continue off of what Liz was saying, this picture right here is from the 2018 maternal mortality statistics, and this highlights our racial and ethnic gaps. If we look here, we can see that African American women are nearly 3 times more likely to die during or as a complication of childbirth. So that's nationwide. However, in Kentucky, we see that white women have approximately 17.2 deaths per 100,000 births, whereas Black women have approximately 42.1 deaths per 100,000 births.
Here is a list of the top 7 causes of pregnancy-related deaths in the US. About 63% of these deaths were preventable, which is a very important fact. The top graph shows the 7 largest causes of death. So for mothers of all backgrounds, the leading causes include cardiovascular conditions, hemorrhage, and infection. However, for non-Hispanic Black women, leading causes of death include cardiovascular conditions as well, like cardiomyopathy, preeclampsia, and eclampsia. And then the bottom chart there shows for Kentucky the percent of deaths related to different causes. And a significant point from this that we wanted to point out is that drug intoxication and overdose is a large issue in Kentucky and something that we need to continue working towards and improving.
So when we're thinking about some of the causes of maternal mortality, I think it's also important to think about the social risk factors that are involved here. So some of the social risk factors that are involved with maternal mortality are going to be things like unstable housing, limited access to transportation, and healthcare facilities. So these are things like a lack of appropriate personnel or equipment, and as well as a lack of knowledge of the warning signs. So the education associated with being able to know when something's going wrong, a miss or delayed diagnosis by providers, as well as the lack of our continuity of care, and simply just inadequate access to care.
So demonstrating the intersectional complexities of maternal mortality, we thought it would be best to walk through a case with our expert panelists in order to demonstrate how these all work together and cause real world situations to happen.
Okay, so I'm going to go ahead and get started and just kind of read the first of, I believe, 4 chunks of this case, just so everybody can get acquainted with what we're talking about here. And I believe Onu just put a copy of our case into the chat so that you guys can look at that as well and follow along if you'd like. So our setting occurs at the University of Louisville Hospital in the postpartum unit. Our patient's chief concern is post-delivery blood in catheter at 5:30 p.m. Here's our history of presenting illness. Louise Waterfront is a 29-year-old African-American female who recently gave birth via C-section to a healthy 3.5 kilogram boy on May 2nd at 2:30 p.m. She reports feeling cold, feeling unwell, and worsening pain. Louise has no prior health concerns or previous hospitalizations. The patient's previous pregnancy was via C-section and was unremarkable. She is currently not on any medications. Louise attended all prenatal appointments and followed a strict health diet, exercise, and multivitamin diet. She is married with 1 child, and both parents are healthy at 65 and 58 years old. Louise has 2 healthy siblings, and she does not smoke or drink. She is an entrepreneur who speaks 5 languages, and she enjoys flying planes and skydiving. Upon seeing the blood in the catheter, Louise's husbands notified the staff immediately. A nurse notified the resident physician, who also notified the attending. So now that we've gone through this first chunk of our case, we would like to go ahead and ask you guys, our panelists, what bits of significant information and issues do you see right now that are prevalent?
So just from a medical point of view, I think anytime you have a post-operative patient who has a complication that you don't readily see, blood in the catheter is not super abnormal, but definitely can be a sign of something more concerning. So that's, a clear clinical thing there. And then also just the generalized, she's not feeling as well as she could.
Okay, yeah. Is there anything else that anybody would like to add to that?
Yeah, I think another takeaway is that she's well educated, she's under 35. There's no indication here, either social or medical, of being high risk. She's well educated, she is not on any other meds, no other health concerns. And, we see that she speaks 5 languages. She's clearly well educated and coming into pregnancy with all the right social and health factors. So she looks good coming in.
Okay, yeah. So based off of that, what would you guys assume would a best case scenario look like here?
Best case scenario and most common scenario is the blood in the catheter is secondary to just a little bit of a traumatic placement, and that she is recovering normally from post-op, early post-operatively, and that she's going to recover just fine would be best case scenario.
Mm-hmm. And as opposed to that, what would you think a worst case scenario might look like here?
The blood in the bleeding anytime, anywhere can be a sign of something that's something more concerning. So, there's always, when you do a surgery and somebody's had surgery before, there's always a concern about injury to nearby organs, the bladder, the bowel, that we worry about in C-sections, even though they're very common.
And for me, I would be concerned that she won't be taken seriously, because I appreciate the comment that you made earlier about, blood in the catheter isn't necessarily something that makes you go, oh my gosh, what's going on? But, I'm a mom of 2 kids, and I can tell you I was pretty healthy. And anytime I saw some blood, I'm like, okay, something's not right. And so I would want someone to take me seriously. And although, when you're in the medical professional, it may not seem like a big deal, but when you just, are a mom trying to have a healthy pregnancy and birth, it's a big deal.
I think the kind of one of the takeaways as an epidemiologist is that even though she's got this, high socioeconomic position, she's well educated on all of that, as an African American woman coming into pregnancy, she still has the same high risk as somebody her age who's less educated, has less income, et cetera, et cetera. She's still at higher risk.
But Representative Scott was saying, I was also going to say that, I agree with her not being taken seriously, that being a very big risk factor and not being listened to, with her feeling like she's not feeling right and that not being taken seriously.
Yeah. Although it is initially taken seriously, it looks like the nurse notified the resident who notified the attending. So at this point, we're still things are going as they should.
Okay. So just kind of based off of everything that we've talked about now and discussed so far, what do you guys think would just be a generalized outcome for this? We talked about the best and the worst case scenarios. What do you think is the most likely scenario?
She goes home with a healthy baby after a couple of days and recovers from her C-section.
Yeah.
Agreed.
Okay. So it's been shown that a higher education level in African American women does not necessarily affect maternal mortality. Why do you think that this exists, this relationship or lack thereof?
We don't know. And that's why this is such a huge issue. We don't conclusively know. We think, that there could be issues related to racism, systemic racism, structural factors. And I would say that's most likely as a chain of events, as a scenario.
Okay, well, I think we're ready to take on the next chunk of our case then.
All right, so the next part, the resident physician arrived promptly at 5:30 p.m. and replaced the catheter. Frank red blood was still present in the new catheter. Physical exam and ultrasound was performed. Ultrasound revealed a large hematoma, which is a collection of blood outside of a blood vessel, posterior to the bladder. The physician started the patient on uterotonics, Pitocin, and Cytotec. These are for uterine atony, which is when the uterus doesn't contract back to the size it's supposed to be. Despite the patient stating she was in pain, no pain medications are ordered at this time. The physical exam results show that she has a temperature of 94 degrees, heart rate of 110, blood pressure of 80/50, a respiratory rate of 24, an oxygen saturation of 93, and a BMI of 23. In general, she seems anxious and restless. Her head, eyes, ears, nose, and throat exam shows that she has dry oral mucosa, no jugular venous distension, and her eyes are clear. Looking at her chest, she is hyperventilating. Her cardiovascular exam shows palpitations and increased heart rate. Her abdomen has 4+ raised fundus above the umbilicus. That is the uterine atony that we were talking about. Abdominal pain. Musculoskeletal exam shows no joint swelling or deformities, a normal range of motion, general weakness. Skin shows dry, diminished skin turgor, cold to the touch, pale, delayed capillary refill. A stat CT and labs were ordered at 6:45 p.m. The attending was notified again, but still had not seen the patient. So, based off of this information now, can you all discuss the significance and what issues have arisen?
So I think we talked about the most common outcome, but what's clearly happening is the opposite. And we mentioned earlier that people not listening to patients, but it's even worse when people don't listen to objective science, and that's what's happening right now. She's showing signs that her body, which is a young, healthy female, is doing everything that it can to compensate, but is having problems.
And they are significant problems. High heart rate, low blood pressure should be, I'm not a clinician, but those should be early signs. She's complaining about pain. And I think that's something really important to note, that her complaints are not being addressed, nor are her husband's. And as of 6:45, there's still no attending on the scene.
I'll just add that she knows her body. I'm going to keep coming back to that because I know that every time, there hasn't been a lot because I'm, relatively healthy, but every time there has been something that wasn't right, I was right. I mean, I don't have to be a medical doctor to know when something isn't right, when something's changed or shifted. And every time I've been right, there was something that was off that needed to be addressed. And she's, it doesn't seem like she's someone who is constantly going to see a doctor to complain about something or others going on. Something just ain't right. She seems like somebody who's, pretty clear-minded and not going to make up pains or symptoms that aren't really there.
So I think one example, besides the fact that the attending isn't there, of potential racism is in not giving pain medication. Often minorities are not given pain medication because there's kind of like this, unsaid assumption that there could be addiction issues.
Also with that, what I was going to say is it's really interesting because there's also like a thing that goes on where people don't take minorities' pain spectrum seriously.
Right. Mm-hmm. Yeah.
Okay, with the next question, what's the significance of her physical exam findings?
Somebody needs to wake up, start paying attention.
So, one of the amazing things about pregnancy is the vast majority of the time it involves young, healthy women, and young, healthy bodies can withstand an incredible amount until they don't. There's not this gradual, slow decline that we see in elderly population. It's actually the most amazing thing about my job is to me, if anyone can survive, it's this person. And we are seeing in real time, slowly, how negligence and attitudes can take a life.
So I'm just looking at the chat, and there's an interesting question from Amanda Williams, who says, I would assume cases like hers do not happen every day. Why hasn't better care been given? And you're right, these are relatively rare events, and that can mean that the processes are not in place and well practiced and rehearsed ahead of time, and thus it is a surprise. It's a rare event. That's a very good question.
I'll just add to that also in the midst of COVID, I just know that we've seen some similar situations where people's symptoms weren't being taken seriously. So while we can't say this particular case is rare, I don't want to write off that Black people still aren't taken seriously. We don't have to be pregnant to not be taken seriously. So I just want to put that out there.
Yeah.
And from a systems perspective, and we haven't talked about this, and it's no way an excuse for the care that she's receiving, but we've seen this in COVID, that hospitals are understaffed and under-resourced and undersupplied. And as a result, you don't know if there's one nurse for 4 patients because that the hospital is understaffed and it's unsafe too. So there are so many layers that are leading to this outcome potentially.
And it's I think COVID has really highlighted the huge problem we have in our healthcare system and in public health. That we are not ready. And that means that our system can fail at so many different points in so many different ways.
All right, so in light of these exam findings, how would you reasonably proceed?
So, I think that this is a patient who needs an immediate attending at the bedside. This is a patient who, if they have no IV access, needs to have 2 IV access. They need more than the attending at the bedside. They need anesthesia at the bedside as well. They need aggressive volume resuscitation with blood products and IV fluids. And there should be strong consideration about taking this patient back to the operating room, or possibly using our other colleagues who can help stop bleeding in with non-interventional forms.
Right.
Okay, and what is the prevalence associated with post-cesarean section complications? Is this prevalence spread differently across racial and ethnic groups?
So I don't know about complications, but we can say that we know that our cesarean section rate overall is too high, and Black women are more likely by about 1.5 times, or about 40% more likely to undergo a C-section. Now that could be because they need to. So, that has to be put in one basket. Complications I can't speak to.
Absolutely. I mean, the complication rate of post-operative infection, post-operative endometritis are all higher in African-American women and minority women in general.
Mm-hmm.
And then there is a question in the chat. What factors in the culture of the hospital or dynamic of the hospital team do you think contribute to such negligence? And how do you prevent this from happening as a medical student, resident, attending, etc.?
That's a fantastic question. So, what's missing here is, we know the attending's not at the bedside, but we don't know about the phone calls that the attending's got. And I think that all comes back to hierarchy, right? We all know it, that's what, unfortunately, just that culture permeates the hospital, especially in academic settings. So it could be that the resident and intern is advocating that get out of your call room, come see this patient, I need help. Or it could be that they're not making a call because they're not comfortable. I think that there's one of the things I've gotten from this case so far is it's like a big game of telephone, right? The nurse tells the intern, who tells the resident, who tells this one, who tells this one. And then if something gets lost along the way, that could be a delay that costs hours because you've already told someone and they may have forgotten. There's so many layers as opposed to just going to the source. So I think for medical students, for residents, for attendings, for everyone, the first step I've always tell people is you yourself go and see the patient and then make the phone calls you need from the bedside.
So somebody's mentioning in the chat that Shanice Wallace was a resident, African-American, died from eclampsia after childbirth last year, and she died in the same hospital she worked in. There's NPR just did a really nice series a couple of years ago on maternal mortality. And most recently, I guess it was about 1.5 years ago, that a woman who was trained as a nurse at the PhD level at Johns Hopkins died similarly. So that just like highlights why this is a good case to look at.
And a reminder that those are the cases that we know, right? They're all the cases we don't know,
Yeah. Absolutely. That's why, I won't skip to your legislation, but we'll talk about that in a minute.
All right, do you all have any other comments, or otherwise we will move on to the next part?
Okay. So the patient's husband asked why the CT had not been done yet while the patient became pale and groggy. The patient was finally given Dilaudid for pain management. Lab results came back and lack of urine output was noted. The first round of labs showed signs of blood loss. A second round of labs was collected 2 hours later, showing rapidly progressing blood loss and inadequate clotting factors. The patient was transfused with 2 units of packed red blood cells at 8:30. Series of blood pressure readings over the next 3 hours were 70/50 and 82/53. Plasma, which contains blood clotting proteins, was administered at 11:30 p.m. Another bedside ultrasound revealed an expanding hematoma and free fluid. The patient's husband demanded to know why the STAT CT scan was still not done. He stated several times to nursing staff that he felt that they were not being taken seriously and expressed frustration that if he were to demand action, he would likely be thrown out. 2 of the doctors recommended surgical intervention, and 1 doctor indicated to continue the course of treatment. The patient was put under massive transfusion protocol at 11:42 p.m. Okay, so what sticks out to you as significant from this chunk of the case?
The thing that really sticks out to me is that meds were only given at urgence from the family. That's really concerning because there's been all these factors that have been happening before that. And then also the partner saying that like they weren't taking enough action.
And that he was scared to push it too far. I think that is really significant. He's advocating for his wife, but as a presumably Black man, he feels like he has to be careful in how aggressive he is in his advocacy, or they'll kick him out, call the cops, whatever.
That is systemic racism.
Right there.
And we don't have to look any further than our emergency department, where we know that Black patients have security guards called on them at rates disproportional to any other group. I mean, like, when you're supposed to be advocating for the ones you love the most, you're worried about things that you should never have to worry about. And it's so disgusting. I also think, from the clinical side, that I think this is the moment where these doctors are scared for the first time, and they do not want to take this woman back to the operating room because I think they know that something bad is happening and it's already too late.
Well, we are looking at 6 hours later.
Yeah. And her blood, and what's amazing, and we talked about this before, is her blood pressure is almost the same as it was. So look what she's going through and look how stable she appears. It's what happens.
Mm-hmm.
Okay, so next, what is the significance of a packed red blood cell transfusion being ordered without plasma or clotting factors in the case of significant hemorrhaging?
It's the equivalent of like pouring water down an open drain. If you can't stop bleeding, it doesn't matter how much you put back into a system, it's just going to come out. And I think anyone that goes into a surgical specialty, anyone that does a surgical rotation will see a patient that is in DIC that has the inability to clot, which is what's happening. And while blood is a good first step, it's just her resuscitation is woefully inadequate.
Okay.
Well, hasn't she already been given? No. I thought maybe she's already been given some bloods. They'd already been through a round of that. Yeah, a second round of labs that's showing progressing blood loss. So they're told time again. And here it is 6 hours later, and she's bleeding out.
And massive transfusion protocol without addressing the source of the bleed. There's no reason for it.
And yet from an ultrasound, they can see a hematoma.
The CT isn't even necessary at this point. They already have their indication to go after their source of bleeding.
And they had that in the first slide, I think, right away. Okay, at 5:30, they started looking at that. So
to go off what you guys are currently talking about, so we note that a STAT CT was ordered at about 6:45 p.m., but it wasn't performed until 11:30 p.m. So what is this saying about her standard of care?
She's not getting the best standard of care. I mean, she's not getting the standard of care. I mean, there are procedural guidelines for this.
This is obstetrics. Women get bumped for the most frivolous things, and you have to fight to get women's CT scans or MRIs. I mean, they just do not, the system values trauma, ortho, all of these things that are just, that are important too, right? But they do not value women, value moms. They don't.
Well, I think something that's interesting is that we've had a huge push in this country in the last 20 years to reduce infant mortality and neonatal mortality. Where are women? Where are the moms?
Mm-hmm.
And that's actually worldwide. You know, we've worked really hard on neonatal. Babies are cute, but maybe their mothers aren't, you know?
Yeah, that's true. That's true.
That's a very interesting point, that maybe obstetrics in general isn't being taken as seriously as some other forms of
neonatology, right?
Yeah, that's really, really interesting.
Yeah, so we've got these like really expensive, impressive NICU units, and you know, level 3, level 2, level 1 NICU units, and ways to transport infant patients. But do we have the same thing for moms? No. So when I did, this is a slight, no, it's not really a tangent. When I used to work with the Preeclampsia Foundation, doing some research with them, one of the things that we found is that there's a real need to tell women, and it shouldn't be women, it shouldn't be up to the women, but it has to be, like if they're, say, a couple of weeks out from delivery and they're experiencing like headaches, blurred vision, anything that's could be related to preeclampsia, they have to not just get themselves to the ER, they have to advocate for themselves, because usually they're sent home. Like, there's nothing wrong with you. You've got a headache, when that can actually be, you know, a predicate to eclampsia.
Yeah. So I just want to go ahead and address a few questions in the chat. So Tasneem is saying, implicit bias training for providers and policymaking targeted towards dismantling structural violence both seem like long-term solutions for maternal mortality in the US. What are some things that could be done in the clinical setting to have solutions sooner rather than later?
Well, I have a bill to address the issue of, well, it's the Maternal Care Act, House Bill 27, and it's designed to do a few things. One is to mandate implicit bias training for medical professionals, and really it's beyond implicit bias training. It's dismantling racism training, because implicit bias is a soft term to use for legislators to make them feel better. But that's not what we're talking about. We're talking about dismantling racism. So that's, you know, one step that we can take, but we have to get past the barriers, which is making sure that medical professionals don't push back against the Maternal Care Act to say, no, we don't want that. You know, Kentucky's chapter of ACOG, you know, if they say to the legislators, we don't want it, it won't happen.
Okay, so I think that this is a very interesting segue into our next question. So how prevalent are acts of medical negligence like this in our community? How is this prevalence, furthermore, how is this prevalence distributed across different racial groups?
The thing with it is we just don't know, because a lot of stuff is unreported. So that's a really huge problem, because we don't have all the information.
It's a good point. And medical negligence is very hard to prove.
And in Kentucky, you know, specifically, we don't do a good job of tracking maternal deaths at all.
No, we don't. We do a terrible job.
There's been numerous like recently like podcasts and things like that about hospitals have a self-serving interest to not be forthcoming about their medical negligence. So if anyone's seen Dr. Death, the podcast, I mean, it's the best example, right? Of people hurting people over and over, and doctors in the hospital saying, you're fired, but you can go practice across the street. And they don't come down hard enough on the negligent provider. Yeah, it's a problem.
So Dr. Miller probably knows more about this than I do, but I do know that a couple of years ago in California, they started implementing trainings that included bias training and anti-racism, but also very importantly, put into place really clear procedures for what if we see a woman like this, what do we do? And then they practice it and practice it and practice it. And for example, they have a rolling, container full of what you need if you're seeing a hemorrhage. Yeah. And that has appeared to be effective.
It's very effective.
It's very effective. One of the things that you mentioned, Dr. Miller, was that, this chain of command where the nurse calls somebody who calls somebody who calls somebody. And we all know that information is lost with each call.
Yeah. Yeah. And for somebody whoever asked about implicit bias training, we actually at the University of Louisville Health are in the process of creating and instituting mandatory implicit bias training, which we're hopeful will go live by summer of 2021, which will be mandatory initially for all leadership within the hospital, because while we have limited resources, it's important to set culture, and will hopefully by 2022 be available and also mandatory as part of online onboarding for all employees of UofL Health.
So I have a question for Dr. Miller. So this panel here is pretty, woke, I guess, to the realities. What if we had, I'm going to say it, an older white male physician on this panel? Do you think they would be defensive or in denial about some of these issues?
I think that you don't know. Yes, maybe not outwardly, but I think that cultural competence comes into a lot of this. So I use this example, right? So in obstetrics, we think of this as like having a baby is like a very sacred moment between a family. So oftentimes moms and their partners are in the room birthing by themselves. And somebody brought up a doula perspective, and this is a great part of doula. So for instance, let's say you have a nurse who's just less comfortable with her room of African-American lower socioeconomic status patients. Well, a lot of obstetrics you can do from outside of the room. I can look at a baby, I can look at a monitor, I can read vital signs outside of a room. I don't have to be in a room. But if I'm not in a room, what I'm not seeing is the small changes in how she's feeling, in her Foley catheter, all these things. And all these little kind of implicit bias, which is why I don't go in that room so often, are what lead to these outcomes, are what make people that are, minority women get caught later in the process. It all kind of builds up. And then vice versa, patients know. Patients know if a nurse isn't feeling them. Patients know if a nurse makes them feel uncomfortable. And it's this other thing where sometimes it makes you advocate more and sometimes it makes you advocate even less. I think we see it most in our non-English speaking patients. If we have a nurse that makes our non-English speaking patients seem like they're a bother, they're less likely to complain. And that's how they get hurt. That's a great place for doulas to come in, because doulas are there to advocate, period. They're there to support you during the birthing process, and they're there to advocate. In San Francisco, where I trained, every minority woman in San Francisco has a doula that is assigned to them by the city of San Francisco as part of their prenatal care that's offered to them.
That's awesome.
That's the level we have to get to.
Yeah.
The thing I was going to say with the doula perspective is that with doula care, you start with a person like pretty early on in their pregnancy, and you build that relationship. So with building that relationship, you also provide education and resources and like make a birth plan and all those different things to help them advocate for themselves, but also acting as a barrier, like between them and if they need something from like a nurse or anything like that. And I think having that is really important in situations that could possibly lead to this, if that makes sense.
And I'll just add that, Dr. Miller, while we're not California, I definitely modeled the Maternal Care Act after California's Act. And I have another bill that I filed this session to provide Medicaid reimbursement for certified doula services. So we're moving in the direction we need to go in to make sure that people who are pregnant have the support that they need to have a healthy pregnancy and birth.
Mhm.
So there's another question here about, could this person have been asked to be transferred to another hospital? My guess is they could, but they're already at the University of Louisville, which is the highest level of.
If somebody's unstable, they cannot be transferred. So you have.
And there's that too, like, right. You wouldn't transfer a woman in this condition.
Okay, is there anything else that anybody would like to go ahead and add? Okay, I think we are ready for our next and final chunk of our case.
So Louise was taken back to surgery at 12:30 a.m. During the surgery, 3 liters of blood were found in her abdomen. Unfortunately, she was unable to survive her massive blood loss and was pronounced dead at 2:30 a.m. Autopsy performed later that morning revealed death was due to hemorrhagic shock, secondary to acute hemoperitoneum, post-cesarean. In order to stop this from happening to anyone else, the patient's husband starts pushing for legislative changes in Kentucky. He pushes for change that requires implicit bias training for healthcare workers, keeping record of pregnancy-related deaths on a statewide level, and greater accountability for hospitals and their employees. What do you all think is some of the significant information in this last section?
That she died.
Died because of all the things that led to that.
This chain of, right,
yeah,
chain of events.
It was a train.
And I think the other thing is that the powerful thing about maternal mortality or FEMR's fetal and infant mortality reviews is that you go through this and you can see really clearly what that chain of events is.
Mm-hmm.
All right, evaluating the overall quality of care in this case, how do you think that affected the outcome?
It was terrible.
Yeah, it's terrible.
Not a better word for it. Terrible.
Mm-hmm.
Disgusting. Like it affected.
Totally preventable. She did not need to die.
Why do you think situations like this lead to medical mistrust in marginalized communities?
I mean, I guess the question is, how could it not? You know what I mean? Like,
right.
This happens not all the time, but there's been a lot of stories of things that have been reported, especially in the past couple of years. And I think that's why a lot of people, some people are going more into like out of hospital births, like with certified professional midwives and stuff like that, because a lot of Black minority people of color feel safer doing that. And if they're low risk, like this person was. So I think there's a lot of medical mistrust because of the systemic racism that exists. And it's just like, how could this not, like, this shouldn't have happened. It just shouldn't have.
And I'll just say everything you said, Cheney, and I'm not sure I know when in this country we ever really had any healing or reconciliation as it relates to medical trauma, abuse, the history of medical racism. I don't know that we've actually ever really done any reconciliation around that in this country. So I wouldn't even say that this leads to mistrust. It adds to the mistrust that already exists.
That's exactly right. And it's not just in the past couple of years. If you look at data going back 100 years to the beginning of the 20th century, the same gaps are there. They have not changed.
I think that's an interesting point too, that the field of obstetrics and gynecology was started through exploiting Black women. And so that's another important part of this too, is that especially in the field of obstetrics and gynecology, that trust is so much more fragile.
I would like to go ahead and read a comment from the chat. Adrian Smith says that the disparity in maternal mortality goes beyond the hospital and healthcare system during a woman's pregnancy. I feel that this is missing from this discussion. When we talk about racism, it's not just the bias they're experiencing in the room. Is there anything that you guys, our panelists, would like to add to that?
Sure. I think that what we're uncovering and trying to find good epidemiologic evidence for is what is the result of a lifetime of racism and trauma to a woman's body. So there's been some work done on something called weathering, that the idea that over time, all these hormones get activated and basically a Black woman ages faster than a non-Black woman. And somebody who's 29, a Black woman who's 29 may physiologically be a little bit more like a 35-year-old non-Black woman in terms of how her body has aged. And we know that 35 is like this demarcation that immediately throws you into high risk. So it's pervasive, lifelong, and intergenerational. And, we're, one of the things that Dr. Miller and one of my students, actually now our students, has been talking about is the role of epigenetics. Like, can we find out what the mother, the grandmother, the great-grandmother went through also?
I use 3 examples when I talk about this because I completely agree. I think that the effects of racism are in our DNA. They're incorporated into who we are, even if we don't know it. So I use number 1 as an example of something that I do every day. Every time you use a speculum or a certain type of retractor on a Black woman, you are using an instrument that was built by their abuse. And you're calling it by name, and you're literally asking for a retractor named after the doctor that abused and treated Black women without anesthesia. It's not in your history books. It's not in your history books. You don't learn it on your OBGYN rotation. Number 2, I use the example of when we talk about risk factors, it is so common now to say Black is a risk factor for diabetes, hypertension. Black is a risk factor, and that gets incorporated. All of a sudden, Black is a risk factor for badness, and that is incorporated into your everyday being. And finally, the laziness of the healthcare system. So Black kidneys are the same as white kidneys, as the same as Asian kidneys, as the same as Latino kidneys. But only in the Black population have you seen that because diabetes is more prevalent, because certain diseases are more prevalent, because it's harder to control, they've said, well, maybe we should just change the GFR for Black people. So that way we don't have to start treatment. So for every group, it's this one, but for African Americans, your GFR is actually this one. So we don't have to worry about it. And we wonder why diabetes and hypertension is worse. It's because the system has abused us from day one. The system has identified us as sicker. And then the system says, but not only are you sicker, we're just going to change our rules and change some of our values so we don't have to treat you just as fine. It's birth to now.
Not, so what I'm constantly telling my students is being Black is not a risk factor. It's a marker. Very different thing.
So all of this, and I'll also add whiteness. We've got to talk about whiteness and what this society has told white people that you have the right to do, which is to prejudge people, to not give people the care that they need, to not recognize that the systems you've designed for yourselves are set up against those of us who are Black, Indigenous, and people of color. So we also have to add that to the conversation, that we have to dismantle these systems. We have to dismantle this understanding of whiteness as the beginning and the end and the way in which we should operate in this country, because it's not, and it's killing people, like literally killing people. The other point is around the perfect victim, like going through this whole story and then to learn at the very end that it's based off of a true story. For those of us who do activism, especially around police accountability, we often talk about how people get mobilized when they see the perfect victim. When they see a Breonna Taylor, who was a young Black woman, in the medical professional, profession, yes, we can get behind her, but can you not get behind a David McAtee, who was a barbecue dude in the West End of Louisville, who the National Guard killed? So in this case, she was the perfect victim. Like, she's, you know, educated, well off, traveled, speaks multiple language, married, right? She's married. So that has something to do with it as well, in the way that she's looked at. So I just feel like we have to take all of that in, the way that whiteness works, and remove the perfect victim from your mind, because we should care about all of the moms and the babies who are dying in childbirth.
So somebody wrote in the chat about if we're doing harm in our conversation by using an old white male as the example of a provider who might not listen or be culturally competent in the scenario. And I think that's true. And we do have to be careful with our words, but I hope that we can approach this with a reframing, because this room is, I think, full of allies who want to do this work. And when you say old white male, I want you to separate the person from that. Medicine is old, white, and male.
It is.
The entire history of medicine, invention, technology, the origins, who got into medical school. When I think of old white men, that is what I think of. I think of the historical structure that has created the system that we're living in, not a person in front of me. So I think we have to go beyond the person in front and being so literal, and think of what has created the system that is failing right now. That system is old, white, male. And I don't think you can debate it. Now, when we talk about, of course, there's bias against other groups. Of course, African Americans, we could have bias against each other. We could have bias against other groups. But I think that we are all working in the system. And when that happens, when we are in that power structure, we are all in that old white male mentality that hurts people. But it's not about an individual.
Correct.
Okay, so we wanted to talk a little bit about the history of this case, because this case actually was inspired by a real story. And so if you wouldn't mind going to the next slide, yeah. So this case, actually, there were a few details that we adjusted, but this case happened to Kyra Johnson, who was a 39-year-old healthy woman back in 2016 at Cedars-Sinai in California. She delivered a healthy baby. She already had a child, and that child was healthy as well. And then after delivering this baby by C-section, she died from internal bleeding from a bladder laceration and medical negligence. Dr. Name was the physician supervising her case, and Dr. Name is still allowed to practice medicine today. He was put on a probation of, I think, 4 years of teaching medicine, but is still allowed to practice medicine. And since this tragedy has happened, Kyra Johnson's husband, Charles Johnson, has founded For Kyra for Moms and has been pushing for legislative change. This was really a huge catalyst for a lot of these conversations happening at a national level. And so after sharing the details of this real life case, what kind of emotions does this evoke for you all? And why do you think this is important?
I mean, emotions are that it's deeply, horrifically tragic. Shouldn't have happened.
I mean, it just makes me very angry because it was preventable. It was so preventable. And because of all the factors that went into the case, and the person being Black, and they just weren't listened to, and it could have been prevented. And that's horrific. It's just horrific.
I think, somebody asked before, what can we do as students, as medical students? And I think everyone in this room, as they read this case scenario, knew what was happening, right? So I think for me, it makes, when speaking out is hard, it gives me more motivation to speak out, because you're doing it for a reason. You're doing it for prevention. And if you speak with the best of intentions, then you can't go wrong.
And it's something we have to be loud about.
Can't be quiet.
Yeah.
You can't be quiet.
And like Attica suggested, has said several times, we're not even counting them properly. And we're not doing reviews of every case in Kentucky and across the country. And that's just, completely inexcusable. We do an infant mortality review for every fetal or infant death, at least in the states I know. Could be wrong, but not a maternal review. And we have a maternal mortality review committee in Kentucky. So we need to count and use the data.
Mm-hmm. So situations like this that affect our current population, what positive things are being done legislatively to rectify them? And what improvements do you all want to see?
Improvements I would like to see, like I'm in midwifery school right now. I'm training to be a certified professional midwife. And I think it's really important, like having just dismantling racism in that structural form, starting from the beginning and teaching that throughout while people are in school, so they can be aware. And I'm really lucky, and my school does that. Like we have like a midwifery and social justice class. We went through the history of midwifery from different cultures and stuff like that. But a lot of people aren't aware of the racism that exists in the medical system. They just aren't. And that's a problem.
And I was just going to add that, like Kyra's husband became a legislative advocate, I believe that everyone can push for legislative change. Our Women's Democratic Caucus on last Tuesday filed a whole host of bills related to maternal and infant health. I encourage folks, check out those bills. You can search on our website, legislature.ky.gov, for maternal and infant health related bills. If you don't see your state representative signed on as a co-sponsor, encourage them to sign on. They should hear from you. There are over 100 people who are on this webinar this evening. That's 100 people who are going to be contacting their state representative tomorrow to say, support the Maternal Care Act, support the bill to provide Medicaid reimbursement to certified doula, support the bill to mandate that the Maternal Fatality Review Board actually issues their annual reports and present them to the community and make them publicly available. Support the bill that says we need to provide better maternal health services to people who are pregnant and incarcerated, so their babies aren't immediately stripped from them. So, I mean, there's so many bills that we have filed, and folks can immediately take action tomorrow and the next day and the next day, so that we are all, advocates for Kyra and other moms.
So I know that Josie Raymond, one of your colleagues, is very interested in similar issues. She lives in Louisville and she's a representative here. I was working with her, I guess, starting a couple of years ago on, trying to draft legislation exactly like this. And we could not get data. Like, I'm an epidemiology professor at the University of Louisville. I should be able to get data, and I can't. That's a problem. We can't study what we don't know.
Absolutely. And again, I think it goes back to how does this happen? I would imagine that the hospital system looked out for themselves way more than they looked out for
too.
My very first days in attending, I dealt with a doctor who recently lost a patient, and she was despondent, she was distressed, it was a freak accident, and an older doctor walked into the room, patted her on the back and said, well, at least she didn't live. That would have cost you millions.
See, that's part of the culture.
That's culture. And that is That is culture. On the flip side, they call NICU babies, they call them $1 million babies, because if you deliver a small baby and they stay in the NICU, that baby's going to get reimbursed and be $1 million for the hospital. These hospitals with big NICUs, those are money-making machines, and they will take every mom that they can get, but they don't care about the mom. They care what's inside, because if they can get that baby into the NICU, that's how they make money. It's the system for which we're reimbursed. Women are not reimbursed, their babies are. Babies are already prioritized more than the mom. It's just the system.
And as I see a comment here that just happens to be from my husband that says, that's capitalism and the monetarization of health and life. Damn straight.
Yep. I have so many moms who say, I am uninsured. The only insurance I get is emergency Medicaid. I have diabetes, hypertension. I think I might have preeclampsia because I have a headache, but I can't go to the doctor until 3 weeks before my due date because I need 3 weeks off because I'm going to have a C-section. So I have to time when I'm going to get care so I don't have to pay for any of it because it's too expensive and I can't afford it. And then we wonder why maternal mortality while we're getting a failing grade in Kentucky. We don't wonder, we know. We just don't talk about it. We know exactly where the problem is.
Yeah.
So with everything that we have discussed about this case, what can we do as beyond being future medical providers or anything like that? What do we do as community members to improve health inequities in maternal health care outcomes?
Call our representatives and support Representative Scott's bill for a start. I mean, make the calls, volunteer to help her put legislation together as professionals. Yeah.
Thank you. And in your own education, ask the why questions that I know social workers are trained to ask. You know, why are we not being taught about the history of medical racism? What have we done to do reconciliation with communities we've harmed? Start asking those questions so that you can begin to dig down deep into how we break down these systems that aren't working for people and build up something that actually is about life and sustaining life.
I'll be very selfish that in my role as Chief Diversity Officer at Uofl Health, as we all know with the current climate in the country, we have the ear of the city, we have the ear of the administration, and our asks can be as big as we want. And I have my ideas, but I know that you guys have so many more and I want to hear them. So I know you guys have seen areas where we're missing that I haven't seen yet. I know that you guys have so many ideas. Don't keep them inside. I would love an email. We can do lunch, coffee, dinner, because I believe in community activism is a great way to spread great care. We're already doing great things, but we can do so much more.
Completely agree. So there's just Liz or Cassidy, you want to read this question?
Yeah. So this question is for Attica Scott. I'm lucky enough to live in the district you represent and know you are advocating for all the issues I stand for, but can you speak more to some of the legislation either passed recently or that you hope to pass in the future related to addressing maternal mortality?
Thank you so much for the question. And I will say a couple of things. One, I'm disappointed highly in this legislative body for its failure to really pass legislation that addresses your very question around maternal mortality. Instead, we've passed legislation to force people to carry a child and give birth against their will. And so while we're doing that, we're also ignoring the very bills that I talked about that we have filed to address maternal mortality, infant mortality, to really create a healthier environment for everyone. So, you know, unfortunately, we have a body that is not willing to engage in these very important conversations that we're engaging in tonight. But again, I will go back to my point, which is that it's everyone's responsibility on this webinar to get them to that point where they're having these conversations. They're not going to do it because they're, you know, just people who understand the issues. They're going to do it because you make them do it. You push them to do it. So you've got to get on that phone and call. You've got to send those emails. You've got to hold their feet to the fire and hold them accountable. Otherwise, we're not going to get anywhere as far as legislation is concerned, because again, we're allowing people to be comfortable in their shells, and that's not helpful for any of us.
Are there any further questions from the chat?
I'll just, to this last comment, my full-time work is in public health. And yes, we have got to address the economic and social issues that people are facing that create barriers to good health. Again, we can't blame people for making the decisions that they have to make. I live in the West End of Louisville, predominantly Black part of Louisville, grew up in the project of Beach Terrace that are currently being torn down. We made the choices we had that were available to us as people who relied on public transportation, who relied on the park, who were making limited incomes. And so we have to address those economic and social issues to make sure that we are creating vibrant and thriving communities, and that people can do more than survive, but they can actually thrive and be healthy.
Mm-hmm.
So,
yeah, I see Jason D. Kings in the chat says we need to stop the divide between clinical and public health practice. And, you know, what I've seen in my career is a wider divide increasingly between the two. And some of that comes from the core structural based beginnings of public health. And what actually our accrediting agency requires. Like, they require us to be completely separate from medicine. And I kind of think that's wrong. I don't get that. Mm-hmm. But who am I,
Okay, and then there's a question from Anna Hagen. From a social services perspective, do you feel as though women and families are represented in being advocated for when it comes to their time in being cared for by the medical community? If not, how do we do better along with supporting and advocating for legislation?
So I think that speaks to prevention and probably to universal health care access, so that it doesn't happen when there's a critical moment that requires that person to sort of touch the medical system. It needs to be happening through the lifespan and through many different avenues, and that's the right to health care.
And I know that part of the question is, do you feel as though women and families are represented and advocated for when it comes to their time and being cared for by the medical community? But really, the medical community cannot be fully separated from politics or social issues. I mean, we just can't separate ourselves out in that way, because it's not real or authentic. And I know that some people may not feel comfortable with this reality, but when I think about the way who makes decisions politically, it's mostly white men. You don't have to like it or not, but it is mostly white men who are making decisions about our bodies, who are making decisions about, who can and cannot get certified, what we're going to do about midwifery in Kentucky. It's politicians who are making those decisions, and they're mostly white men in Kentucky. There are very few states, Nevada's one of them, where it's, predominantly women, but also white women fall into the trap of following white males' guidance. When I, just a couple of years ago, had a colleague who's a white woman stand on the House floor and say that part of the problem with women today is that we don't wear dresses, that's coming from what a man has put into her head. So we cannot fully walk away from this conversation about the responsibility of older white men at all.
Right.
Earlier in the year, as people were talking about the arguments of things like defund the police and reallocating funds to social services, I just couldn't help but think how well that idea could go towards medicine, because so many of our patients don't need more pills. They need the support. They need rides to the doctors. They need to figure out how to get their kids to daycare that's what we need. And And one of the things that I struggle with in medicine is it's this artificial environment where we have still not enough, but like social workers, support, dietitians, and things like that. And then we make the patient better. And then we're like, cool, we fixed you, go back home, with none of the resources that they had. And we pat ourselves on the back, but it's just this artificial thing of like, we make ourselves feel better by making our patients sicker because we're not caring for them when they're home. And it's
a fabulous point. Yeah.
What I was gonna say, it's just like such an accessibility issue. Like, how, if people don't have access to like good nourishing food, then how are they going to do all these preventative measures to have good healthcare throughout their whole life?
Yes, and Representative Scott just posted where you can find your state legislator, which I just actually did on the side because I can't believe I don't know who my legislator is. That's just appalling.
Agreed.
And I will write to them.
You're a good writer.
Do you all have any other questions for our panelists? And if you think of your questions later, you can send an email to myself or to Onu or Cassidy, and we would be happy to redirect those questions to our excellent panelists, especially if you have ideas like Dr. Miller was saying. There was a question, what was the bill's number? Oh, HB 27, great. So this slide here, we wanted to take a moment to reflect on, we've talked about some actions that we can take to improve maternal mortality. But when I found this figure, it really got me thinking about the level of impact and how it's important. All these different portions of the pyramid, we need to make changes at every level, but it's important to see what are the most important changes. So addressing social determinants of health, like Dr. Miller was just talking about, reallocating funds to community services that will actually be preventative measures rather than while they're in the hospital, improving how they're treated by physicians or other healthcare workers, things like that. So if you all have any suggestions that you wanted to make right now, we would definitely entertain some of those ideas. Otherwise, if you want to use this as food for thought, there is an event on Thursday night, which we will talk about more at the end of this, where you might be able to express those actions there.
If I might, I have another action item, and I mentioned this a few weeks ago when I was on with y'all, but it still stands, especially after Tuesday of last week when all of these bills around maternal and infant health were filed. Some of us would love for some students who could, turn out a one-page document that breaks down some of our bills for folks just in terms that are not so political. The way we write bills are just intentionally confusing, and we use words we don't really need to use, but it makes us sound smart. But it also makes it difficult to understand what we're actually saying. So I just want to put that out there as something that folks could do, which is just help us with one-pagers for some of our bills that we've filed around maternal and infant health.
Good idea.
Edward in the chat said that he thinks public health externships and hospital systems would be great. And I think that's a really excellent idea.
Mm-hmm.
Someone else is also saying it would be nice to involve some of the public students in these efforts to bridge the clinical and public health gap we discussed.
Completely agree.
Okay, so with all of this being said, we just wanted to go ahead and take a few minutes to talk about some community resources. Some of these are focused more on maternal mortality, and some of these are focused more on infant mortality, and some both. But I believe that they're all worth a mention if we can just go ahead and click forward once. So the first group is the Public Health Maternal Mortality Review Program. So their mission is to provide leadership in partnership with their key stakeholders to improve the physical, socio-emotional health, safety, and well-being of all Kentucky women, infants, children, adolescents, and their families. So we actually partnered, our organization actually partnered with their Safe Sleep Kentucky initiative. So that's really interesting. If we can go ahead and click forward again. So Hear Her is a CDC campaign that's committed to healthy pregnancies and deliveries for every woman. So something that they really encourage is for people to focus on listening to the woman for her needs. I think Representative Scott mentioned that earlier. So this was really interesting to see this in our resources. Can we click next again? So HANDS is another Kentucky group. So HANDS stands for Health Access Nurturing Development Services. So they are a home visitation program for new and expectant families to help build a safe and happy environment as their families grow. Next. Thank you. So Healthy Start, which is another group that we, another initiative that we partnered with, works to reduce infant mortality rates specifically in West Louisville. So this is very local. So this is one of only a few initiatives across the country that had no infant deaths between the years of 2002 and 2005. So they help to ensure women get care prenatally, and they continue to meet with these women after birth to provide various resources. And then lastly, if we click forward one more time, we have the Healthy Babies Initiative, which is another one of our partners. So they work to reduce preterm birth, low birth weights, and infant death. They support policy to expand paid parental leave, as well as expand community access to doulas. They increase access to long-acting reversible contraceptives, and they provide breastfeeding and educational supports to OB providers. They are also creating a stigma intervention plan. And I believe we're ready. Yep, there we go. The next slide.
So lastly, Attica Scott has talked about extensively some of these efforts that are going on, but we just wanted to highlight some legal initiatives. The link at the bottom of this slide, and we'll make sure to send this out, is a good comprehensive link of legal actions that are at various stages of development across the nation. But really the Preventing Maternal Deaths Act of 2018, this established the maternal mortality review committees in states and the ability to get funding for research around these topics. So this was really like the catalyst for this conversation to become a national topic, for research to gain a little more funding and easeability, even though we're not seeing that so much in Kentucky. And then Attica Scott talked about the Maternal Care Act and about the House Bill 138, which would extend care through Medicaid for doula services, for implicit bias training. I don't know if Representative Attica Scott, if you had anything else you wanted to add.
No, except that we have a whole host of, I shouldn't have said no, I should have said yes, that we have a whole host of bills that we filed last week related to maternal and infant health. And what I'll do is I have a legislative intern from Uofl. I can have her put all of those into one list with links, and I can send those to ONU to send back out to folks later. Thank you.
So I'm just going to say something that'll probably get me in trouble, but I have actually offered my services to the Maternal Mortality Review Committee. and to Healthy Start of Louisville. I have a long history of Healthy Start's a national program. I've been working with them since the 1990s in Baltimore, in Des Moines, Iowa, in Palm Beach County, Florida. I can't get a call back. I can't get it. And I was told from the Maternal Mortality Review Committee that they were just fine. Thank you very much. So that's structural too.
That's really unfortunate.
Yep.
We do want to go ahead and take this moment. Thank you guys so much for being here tonight. It really means the world to all of us. And we just wanted to take a few minutes to just let you guys know about some upcoming events. So on Thursday, that's our Growing Leadership and Advocacy workshop. So this is completely free. And this is something that we can all hopefully participate in. And it teaches us how to get in contact with our legislators, among other things. And on Saturday, we have our Baby Box and Virtual Memorial Walls event. And this is really, really cool. If you guys would like to sign up for that, that's free as well. We will be working together to put gift baby boxes, as well as write encouraging messages to victims of maternal and infant mortality. And then next up on Monday is where we begin our next week in our health disparities series. And we kick that off with digging deeper into diabetes, which is another educational panel.
Yeah, thank you. So thank you all so much for coming tonight. I do want to give a quick, I actually did never introduce myself. So I'm Onu. I'm the co-founder and the director of education for this program and for everything else for the series. And I do want to give you just a quick understanding of the flow of each week. So we want to start every week with an educational panel. And the goal of that is to initially plant that seed of like, okay, here are the facts, here's what's going. And each panel features some of the brightest minds in Louisville and Kentucky, talking about these issues on multiple levels. And then from there, we're going to give you an opportunity to work in an advocacy initiative. So our amazing director of advocacy, Zoha Mian, has been creating different ways for you all to not only actually participate in advocacy and writing letters or calling or different forms, but also have someone who is in that realm to give you a quick rundown of what to do, how to do it, and best tips to make it something that's more fun and something that you're willing to do more often. And then we wrap up each week with a bit, especially now with everything being virtual and online, we kind of wanted to find a way to get you all out in the community and actually taking a proactive step, an active step in all these different disparities. So every Saturday or during the weekend, there is some type of initiative for you to be able to do something with your hands, do something with your voice, physically do something. It's all different, unique. It's all going to be unique and creative. And that's the goal. Is these health disparities are always written on paper, and we see it every single day. However, trying to turn something that's written on paper, these numbers, these stats, and turn it into something that moves you and makes you want to get out of your seat and do something is the goal of Grow 502. So throughout these different weeks, that's the kind of flow. And definitely we understand, we don't expect everyone to go to every single event, but we do hope that you find something that moves you and something that gets you out of your seat to go do something. So thank you all so much for coming tonight. And I will send out this PowerPoint, and here's some of the references for this. And that's pretty much it. If anyone has any questions or last parting statements, I guess this will be the moment to post in the chat. And any of the panelists, if you have anything you would like to say to wrap up tonight, here's your moment.
Thank you. And I'll just reiterate what I said before, that everyone tuning in has the ability to really push for change. And so I encourage you to do so. I hope you take action, whatever you feel comfortable doing. If you call the legislative message line, you'll actually not ever reach your legislator. You're going to reach the amazing switchboard operator. So please don't be nervous, just shake it off. And if you email us, that's, you don't have to have direct engagement if you don't feel comfortable doing that. So again, I just encourage folks to please take action. Thank you so much.
All right, well, thank you all for coming tonight. That was honestly an exceptional panel. I mean, it was very moving, and thank you all the panelists for taking the time out of your day to work on this. And trust me, they've all been getting so many emails from me. They're probably happy to finally be done with me, but I thank you so much for coming together
Thank
today.
you for putting this together
Yes.
and making it happen.
So,
All right. Well, you all have a wonderful night.
You too. Thank you, everyone.
Okay, I'm going to end the webinar.
Thank you, David.
Thank
Thanks,
you.
everyone.
No problem.
And